Thanks, everyone. I had the opportunity to talk about this study yesterday with my research colleagues, so I'm excited to talk with all of you today. I'm going to talk about treatment delays in Lyme disease and the risk factors and consequences that we've observed in our study. So this study was conducted by the Environmental Health Institute, which is a joint effort between Geisinger and Johns Hopkins School of Public Health. And with funding from the Stephen and Alexander Cohen Foundation, we've been working both looking at epidemiology of Lyme disease using our 20 years of electronic health record data, and also the consequences of delays in Lyme disease treatment. And we're working in collaboration with John Alcott and Allison Redman at the Johns Hopkins Lyme Disease Research Center. For those of you who don't know, Geisinger is located in Pennsylvania, and Pennsylvania has a high degree of burden of Lyme disease. The most confirmed cases of Lyme disease in the US every year since 2011. And so our study population is located in Pennsylvania. Geisinger covers about 45 counties in Pennsylvania, so central Pennsylvania up into the northeast and down into the south. So we cover a large geography of the state. So what do we know about delayed treatment? The epidemiological studies that are out there, they primarily have been in patients with Lyme disease who have neurological complications. And from those studies, we know that there's an increased risk of disseminated infection. We know that there's an association with persistent symptoms after treatment and poor health-related quality of life. There have not actually been a lot of studies on the association between delayed treatment and post-Lyme disease syndrome. And so I'm talking about not just the persistent symptoms that come along with that, but also the persistent disruption in function and your ability to live day to day. Post-treatment Lyme disease syndrome does not have any current treatments, so we've heard a lot of exciting things this morning about some ideas that might come and really be helpful to these patients. Until we have those, we really need to think about prevention. And one avenue for prevention may be to do a better job in shortening that window between when your symptoms start and when treatment starts. So the studies that have been out there so far have really looked at this big time window as one piece of information from symptoms to treatment. But there's a lot that happens in that window. The first part is when you yourself are suffering with your symptoms and you're trying to decide whether or not these symptoms warrant a visit to the doctor. Maybe you don't have that rash that you always think has to come with Lyme disease. Maybe you don't have insurance, and so it's a really big decision to go to the doctor or not. Then there's that second window when you do get to the doctors, and at that point we have nurses and doctors and testing and a whole host of other things going on. So these windows are very distinct, and we hypothesized that the risk of delays in each of these windows might also be different. So our objectives were to identify the risk factors for treatment delays, both before and after seeking care, and to evaluate the association with post-treatment Lyme disease syndrome. So this was a population-based retrospective cohort study. We identified our patients in the Geisinger electronic health record as patients who either had a Lyme disease diagnosis or they had a Lyme disease blood test followed by the prescription of an antibiotic within 30 days. And we kept it relatively recent, 2015, 2017, so people could be able to recall what happened. We ended up sending questionnaires to 5,300 individuals. And then we did require that in the questionnaire that they report that they either had a rash or self-reported a positive blood test. And in the end, based on the respondents, we had 1,363, we included 778 in our analysis. But because we pulled our patients from our electronic health record, we have data on our responders and our non-responders, so we were able to use some inverse probability weighting to mitigate some participation bias. So all the analysis you see here is weighted. So who are our patients? This was sent to adults so that they could describe their experience before and after care. The average age was 53 years. It was close to a 50-50 split, male-female. The Geisinger health system, we do have an insurance side, but you're not required to be insured to go to Geisinger. And this will become important later. But so we had people who are privately insured, about 78%, but we also had some uninsured Medicaid and Medicare patients. Initially, we had a highly sensitive definition for post-treatment Lyme disease syndrome. It was based on patient responses on both symptoms and function. And so you see, oops, sorry. We had 25% initially was our estimate of PTLDS in our study population. We then worked with Allison Redman and John Alcott and used the definition that they worked so hard to develop for our research. And when we did that, it was actually about 12%, which is about what you're seeing in the literature. So our key findings, so that first window from symptoms to getting to the doctor, the median time in that first window was 7 days, but about a quarter of patients took more than 14 days to get to the doctor. Once they got to the doctor, the median time to treatment was 2 days, which is good news, but 21%, it took more than 2 weeks from when they got to the doctor until they got treatment. And when you sum these two windows together, about 1/3 of patients, close to 1/3, it took more than 30 days from symptom to when they got treated. Now, we looked at what was contributing to people who took more than 30 days to get that treatment, and it was actually both the first and second window of time were both equally important in that delay experience. So we wanted to look, So the next thing we did, we asked people about when they first got their Lyme disease symptom, what did they think they had? And 21% actually initially suspected they had Lyme disease, but the vast majority suspected something else, the flu or a virus, a bug bite, a muscle strain, and these are things that might not lead you to go to the doctor. When they went to the doctor, about 61% chose to go to their primary care doctor, but about a quarter went to urgent care, and there was about 12% went to an emergency department, and others went to specialists. Once they got to the doctor, this pie graph here, that blue that you see there, 56% reported that the first time they went to the doctor with their symptoms, they were in fact diagnosed with Lyme disease, but nearly half were not. And people like Dr. Spector this morning would have fallen into being misdiagnosed at that first visit. We had some people, it was a flu or virus, muscle injury, cellulitis, some of the same things that the patients kind of self-diagnosed initially, it was reaffirmed when they went to the doctors. 68% did receive an antibiotic at the initial visit. May have been for Lyme disease, may have been for another condition. And 13% reported that they had to see 3 or more doctors before getting their diagnosis and treatment. So the first thing we did was we wanted to identify the risk factors for delay in that first window, symptom to seeing a doctor. We called a delay of more than 14 days, we call that a delay, so if it took more than 14 days. And you see here, if you were uninsured at the time, you were more than 3 times as likely to delay seeking care for your symptoms. And this was consistent with a study we published last year. It was a qualitative interview study where people reported suffering from all kinds of symptoms and just held on because they were not insured. This gentleman ended up with Lyme meningitis, but it was about a Wednesday when his symptoms started, and his insurance was kicking in on Monday. So he laid in bed the entire time, his fever rising and rising and rising, and just waited till Monday to get him. So we know this is happening. If you didn't have a rash or you were sick during the winter or early spring, you were more likely to delay care. If you didn't think you had Lyme disease but thought you had something else, you were more likely to delay. But if you went to an urgent care clinic, instead of waiting to get an appointment with your PCP, you actually reduced that time window. Once you got to the doctor, some of the same things that resulted in delay in getting to the doctor also delayed treatment. If you did not have a rash, or again, if you came in a season when the doctor might not be thinking Lyme is even possible, then you were more likely to have a delay of at least 2 weeks, more than 2 weeks before getting your treatment. We also found that people who reported a prior diagnosis of chronic fatigue syndrome had an increased risk of delay as well. We only had a small number of patients in our sample with chronic fatigue, and we don't know if the chronic fatigue was masking symptoms or that in fact they never had chronic fatigue and the doctor misdiagnosed them initially, or they are co-occurring. So there's more work to be done. We did find that the odds of post-treatment Lyme disease was 2.46 times higher among those with treatment delayed for more than 30 days compared to those who were treated within 30 days. So that window of time does matter. So our conclusions, treatment delay remains a problem in Lyme disease. In our population, about 1/3 of people had a time of more than 30 days before getting treatment. Some other studies have also shown a good proportion of patients with a delay, and that delay of 30 days mattered when we studied it with post-treatment Lyme disease syndrome. And again, in the absence right now of available treatments, prevention is key, and so we have to figure out how to prevent these delays. And we learned that it's not just what happens after you get to the doctor. So improving diagnostics is critical, but we have to get the patients in to get those diagnostics done. And one thing we need to think about as we improve diagnostics and as we improve treatment is that the uninsured, at least in our study, and of course in studies of other diseases, are more likely to delay getting in if they think they can't afford them. And so to try to consider that when we're developing all of these great ideas. Finally, utilization of urgent care settings may help to reduce delays. We have to just make sure our urgent care settings are also set up to diagnose and treat Lyme, and we heard yesterday about some exciting education opportunities for urgent care clinics. We had some limitations I'd like to acknowledge. We did not require a blood test to confirm Lyme disease for this study, and that was because, of course, it's appropriate to treat people who have EM rash without doing the test, or even if the test is early enough that it wouldn't be positive. And if we excluded those people, then we would end up with an overestimate of treatment delay, which we didn't want to do. Yes, this was one health system, but you saw we have a huge geography that we cover at Geisinger. More than 44 community practice sites, 3 hospitals, many urgent care settings. And so there's treatment variation and diagnosis variation within our system. And also, because we used both EHR and questionnaire data, we were able to capture not only what happened at Geisinger, but also what happened before they got there, because we asked about before and after they got into the system. So in conclusion, treatment delays remain a problem. We know they're associated with some consequences that are quite severe in Lyme disease. And in order to prevent them, we need to target both public and our healthcare professionals. Thank you.